So what we're going to do is we're going to have like a mock ethics committee. We deliberated on getting a name for it, whether we should use the word mock and all that. Prof. Joseph was a bit kind of like, are you going to say like mock? Are we going to make a mockery of the whole thing? But I promise we are not. I mean, even if we say false ethics committee and all that, it's going to have a bad connotation. But bluff or whatever, it's still going to be. Basically, what we want to do is we hope that we can, that you all can apply what we have learned in these 2 days to practical situations, to the dilemma cases that a lot of us have. Some of us may be in ethics committee, some of us are planning to start ethics committee, and I hope this will be useful. And so I've invited 4 esteemed ethics committee members here, and the 5th ethics committee member is all of you. So I hope you all will have your phone ready. We're going to flash sort of some poll EV questions that we wanted you all to vote. And what's going to happen is I'll describe the case. We'll come to a question that was posed to the ethics committee, a referral. I want you all to vote. And then I'll invite comments from you, why you choose what you choose. And then I'll get our ethics committee to comment as well. So I'm an oncologist, so it has to be an oncology case, right? So this is a 15-year-old girl, M, who was recently diagnosed with chronic myeloid leukemia in chronic phase. Recommended to start on oral chemotherapy, which is a tyrosine kinase inhibitor, which is actually the drug I was talking about this morning. It's one of the first drugs that is targeted drugs that have been used. By the way, these cases, this is a composite case, okay? So I hope people don't recognize it, but it's a composite case. So each problem is real, okay? Just as a background of what chronic myeloid leukemia is, in the past, the standard or recommended treatment for chronic myeloid leukemia for the best chance of cure is to do a bone marrow transplant. But now, ever since we've got the targeted drug, imatinib, Gleevec, there is an option not to do bone marrow transplant. In fact, the cure rate is very good. But of course, then when do you stop the TKI? And that's the problem. Sometimes when you stop, it comes back again. So you might actually have to pay more when you go on the targeted route than if you just do transplant. But when you do transplant, you're going to have lots more side effects. You might have even death. You know, that's one of the risks. Of course, it's not to say that you're not going to get side effects on Gleevec. You can, but probably less than transplant. So she comes from a family of 3 children, right? The eldest sister is 19 years old. She's working in sales. The younger sister, P, is 9 years old, who had perforated appendicitis with peritonitis and severe sepsis at the age of 7, and was in hospital for more than 2 weeks, requiring ICU care for the first week. So a really traumatic time for the 7-year-old girl. She's a single mother, divorced, working as a bar hostess. The father has remarried and has moved to a neighboring country, not so far, has minimal contact with the family, although he does provide financial support occasionally for the 2 youngest children, because the eldest one is already working, right? So the 2 youngest children are pretty much latchkey kids, right? They buy their food after school, they let themselves home. There's no constant adult supervision, as both the mother and the eldest sister works full-time. The eldest sister often comes home late or stays overnight at her boyfriend's home. So basically, these 2 kids are alone at home. So initially, M responded to therapy, but then on surveillance, her tumor markers started to rise. And although she still remains well, the primary healthcare team have concerns that there is non-compliance. Okay, there's no supervision, right? We can only take the child's word that she takes her medicine. So what can the doctors do at this point in time? There are alternative treatment options. One, if there's true failure of the first drug, there's an option to switch to another similar kind of drug, a similar family of drug, the TKI, but more expensive because it's a newer generation. Or go back to doing a transplant. Okay? So these options were presented to the mother and M, and then compliance to the current medication was reinforced. M said, swears that, I took my medicine, but, she's 15 years old, right? So meanwhile, the family, meaning the 3 girls and the mother, was typed. And P, with the youngest sister, was found to be a match, okay, a complete match for her sister. However, when P found out about it, she was very distressed, and she refused to be a donor, okay? Her mother feels that this is because of her traumatic experience when she was 7 years old when she was hospitalized. Mom actually prefers the transplant option because she sees transplant as the definitive and decisive fix. You don't have to take medicine for a long time, right? And she's of the opinion that P is too young anyway to make a decision. And she can make a decision for her to donate her stem cells to her sister M. So the first referral to the ethics committee was made. The primary medical team refers to the ethics committee to ask the question, is it ethical for P to donate to be M's donor? Okay, so this is the QR code. So if you all go onto the QR code and please vote. Yes, it is ethical. No, it's not. I don't know. And it depends. You guys can vote too if you want. Oh no. Oh, okay. Wow. So while the rest of you are voting, could I have some comments? Or you don't have to reveal what you actually voted for, but you can make comments for or against whichever option that you thought of, or you want to say something against certain options before I invite our ethics committee to comment. Anyone? Yes. Thank you.
It's actually a very proved and definitive treatment, the stem cell transplant. I think we should convince, or we should definitely go ahead with the stem cell transplant with the MP being with the donor.
So that means convince the sister, to try to convince the sister.
She's too young to decide by herself. And yeah, it stems from her traumatic experience, but I think that's not an explanation for such a major decision for her sister's treatment.
Okay, okay. Yes. Julian has.
Yeah, so I think it's important to recognise that the stem cell donation has a finite risk of mortality and also significant morbidity, and this girl is got an alternative and just doesn't want to take it. She's too lazy to be compliant. So you're exposing, a child to a risk of death. Which
the donor, you mean?
Yeah, which is not necessary.
Okay. So make the child take the medicine. But that's also a practical thing, right? How are you going to make the child take the medicine? She's 15. Any other, I think, Doctor?
I think the question is the primary medical team refers to ethics committee to ask if it is ethical, not whether she is going to do it or not. So it's a question of ethics.
Yes.
And here, if it is ethical, yes, it is ethical.
Yes.
The only issue right now is to see whether she is going to allow it or not.
Okay.
Whether she is going to accept it or not.
Right. So the ethics committee just gives the suggestion, not how to do it, but to tell them it's
yes.
ethical for P to be M's donor.
Okay. It is permissible.
Okay.
But how it is going to be convinced to the child to do it is a different matter.
So it's permissible even though P has stated that she doesn't want to do it?
Well, that's the next step. The first step, this is a theoretical question.
Okay.
It's a very theoretical question. It's not a question the question should have been that the primary medical team refers to ethics committee, and is it permissible for her and allowed for her to, despite her objection, to compel her to donate.
Right. Okay. So maybe we shall refine the question. Very good. Thank you. Yes, Prof.
Very often referrals are vague. So don't hesitate to ask and say, reframe your question.
Yes, these are real things, right? And we want to sort of have practical advice as well. So yes, reframe the question. What is it that you're actually asking? Yes, Kumu.
just you wonder, because the primary medical team is actually M's primary medical.
Doctors, yes.
Yes. So P probably needs an independent medical team to make an independent decision regarding whether she assents to it or not, or why she doesn't assent to it. I mean, that's how I see it. That's why I say it depends, right? Okay. It really depends, right? So, and there's a lot of people that need to be asked a question. So whether it's the primary medical team that asks P, which I don't think they should, whether it's the clinical ethics committee that asks P, I don't know whether they can, depending on what the composition is, or whether it's a separate team that asks. And I think that, is because you have a donor who is going to be a patient, you have a recipient who is potentially going to be a patient. Okay. So you need to be able to...
Right, so conflict of interest. Okay, so the medical team for M should not be the team that's trying to persuade P to donate. In fact, actually, they shouldn't be talking to P. It should be another team that should be talking to P about why she refused to donate and, assess for fitness. Okay, maybe, sorry? Yes, it should be.
Can I just ask, are there any other adult options, for donors? Has that been investigated? Then the other thing is the relationship between P and M. Okay, good. So is this the only option? Are there other options? What about the parents? Nowadays we do haploidentical and all the kind of thing. Are they unrelated? So yes, is this the only option? But if the medical team can come back and tell you it is the best option based on match and all that kind of thing. So but you need to ask, right? Is this the only option? So maybe at this point I can invite the committee to give your comments.
Yeah, it's okay. Okay, well, I think when sitting on the ethics committee or an ethics consult, the first question I would ask is, is this case clinical consult, ethics case clinical consult, or is this an ethics committee deliberation? I think there are different practices in different institutions, and I would establish that first. But given the case, it sounds, and given the context, it sounds like this is an ethics committee deliberation. You're sitting in a committee and you're discussing, and the different institutions do it differently. Sometimes you can have it as everyone in a room and discuss this as a board meeting. Sometimes it's an email consult with various inputs. Different organizations do differently. But putting it back to the question, each time I get an ethics committee deliberation question, I would have to unpack the question. And there is a final answer a final response, not an answer, but a final response that we give. But there is a process to obtaining that response. And I think all the questions which have been raised so far are part of that process in getting to that response. The first part of it, I would think, is, as what Prof. Roy Joseph was saying, is the question framed correctly or not? Are they asking the right question or not? And I know in that sense, I think it's important for the primary medical team to put the right question forward. Okay. And then we come to that issue then of, how do we approach that process? Well, I would take more typically a four-box approach. That's a big, sort of roadmap towards getting through to that final response. And as a start, I would then look at the medical indications. I'll look at the evidence for the particular therapy. And I think that's where we could start with that discussion. I think evidence precedes ethics, and you need to build the ethical discussions on the good evidence and to look at the various options, the primary option and the alternative options. So in this case, first of all, there's one option, that's transplant. Second, there's an option of, Gleevec and the potential for, continuing on further therapy for tyrosine kinase inhibitors. Or could we consider an option of subsequent transplant again? And that all depends on, the inputs from the medical team. And when I'm looking through that initial referral, I'm looking for all those inputs from the medical team as with respect to what are their primary medical thoughts and opinions for that particular situation. What is their primary therapeutic aim, and what are their secondary other objectives and aims? I'll stop there for now, and probably we can talk about the rest later.
Thank you. Any other comments? Anyone?
I mean, this is part where the ethics will just keep quiet because everyone is doing very well. But I think I just wanted to echo, again, it goes back to, we are assuming that bone marrow transplant is the best option now. And I think it needs to go back, and always we question the clinician, even though we are the same field, but it's good to actually just ask again and again, is this the best option going forward? And since you have an oral medication, and the part that I get a bit disturbed sometimes when we actually send off for HLA without really proper counseling, because once you do a diagnostic and you are planning for something, and if you're not ready for that, and whether you should actually embark for that screening itself, But it's something that we always do, but something just gets me thinking.
Okay, thank you.
Just a short comment.
I personally kind of prefer, first of all, obviously, I think asking questions was a wonderful idea, and thinking about what the question is. I think a lot of times even the clinical team does not really know, but even if they've approached the ethics committee, that is a good thing. We can explore with them what actually they should be looking for, or what we all should be together looking for. The other thing is, I believe one thing which helps usually is to, and it's not easy to do, is to kind of take off that, coat of physician or a clinician, and try to, because we're not thinking as clinicians when we're sitting here and deliberating over a case. So technically we are thinking more of ethics and, kind of more of values and what's happening with the family, and what probably are the moral deliberations are. So and I think intentionally we have to tell ourselves that we really don't need to go into, obviously medical indications, those are important, but like not think as a clinician, because we very specifically, and at least in our part of the world, very authoritatively think in a very certain way. Other thing I think which helps is kind of following any framework, whichever suits the situation. 4-box method is a good method. Some of us have used CORE. I think 4-box method helps in understanding the whole situation, but still we have to analyze and come to some sort of recommendations. I personally prefer going towards negotiation or mediation style of consultation, which if it's like in an initial phase, that might be a possibility. Sometimes it's totally impossible to kind of negotiate, but still we have to bring some recommendations to clinical team. But if possible, mediation, I believe, is a better way, because earlier we talked about consensus. It's so difficult to gain consensus, and I think even voting, I don't know, I have my reservations about that, not necessarily if most of us vote for something that might not be the most ethical solution. So for me, I think personally, going towards mediation in some way is kind of a possibility. Talking to everybody, family, the clinical teams, what their apprehensions are, what's happening, because I think one of the common things that we all often do, or at least I have changed that in my practice, is to kind of giving a solution or coming to a recommendation or a final decision immediately, and not stepping back and looking at the bigger picture and asking why somebody's refusing, or why this is happening like this. So I think having a framework to think about is usually a good way, whichever framework we're using. But personally for me, mediation, I believe, is part of consultations, and if you're specifically talking about clinical ethics consultations.
So sounds like you want the compromise of Dominic's 5 Cs. Is that right?
maybe, I don't know where, I mean, like, that would be like, for me, it would be a win-win situation if the family and clinical team, they come to a conclusion together, in a way that they could find some sort of resolution that everybody gains something at the end of the day. So
okay, okay, Sumi.
Look, I would just say to this teenager, do you love your sister? I mean, seriously, right? Because she must know about the trauma that she encountered from the previous hospitalization. And, this procedure puts, will probably traumatize the sister. So if she's playing around and not taking her meds, I mean, I wouldn't put it quite like that, but you know what I mean. If she's playing around and not really taking her meds, then she's only hurting herself and potentially hurting her sister if the path down the road is to consider a bone marrow transplant. So, they're latchkey kids together. I would think they spend quite a bit of time at home with each other. Is that what she really wants when there is already a solution which would work work well, and doesn't have to put her at risk?
Okay, some very good points raised, and what John was talking about is the type of ethics committees that we have, or ethics deliberations. I think in Royal Children's they have an ethics team that mobilize within quite quickly, but they are all physicians, all healthcare professionals.
At each ethics meeting, there'll be some clinicians who are there with an ethics hat on, and there'll be some ethicists, and then there'll be the treating team as well.
Right. So, and I think in the States, they have this thing called ethics consultants, where it's actually like a subspecialization. They go to the ward and they take a history, and they come to their own sort of analysis and all that. So in KK, what we have is we have an ethics committee, not an oversight committee, but the committee that decides, and we have lay people on the committee. Okay, so I think it's important to sort of know what you have to work with, okay, before you kind of deliberate. Yeah, we see you want to say something.
Yeah, I think it really depends on what you have, and also what type of cases, and I think every hospital will be doing differently. So if we were to have this, I mean, we would probably have a bit more time to actually deliberate it in the bigger committee. So we have a bit of a diverse committee as well. And we have a small team which is a bit more trained, but still learning, but had to actually be there because some things needs to be sorted out a little bit faster because you can't bring everything to the committee. So I think we are still evolving. Yeah.
Yeah, I think also to be aware that, I mean, there are different levels of ability. I mean, not every place has the advantage of having trained ethicists, and I think a lot of times the people on ethics committee are arrowed to be on the committee. A lot of them are sort of doing it without kind of not real training. So I think you just have to know what you're working with. And the other thing is to ask questions. I mean, whenever the referral comes to you, you mustn't take everything at face value. Sometimes certain things are hidden or certain things are not even thought about. I'm just curious to know whether anybody else has any sort of information you think is not provided here. Yes, cool.
I just have a question about the medication. So
yes.
The assumption and the judgment from everybody is this teen is not taking the medicines. But is it possible that they are and it is failing? So if they really are and it is failing, this may be the only option as bone marrow transplant. Yes?
Yes.
So I think that is a feasible enough question to ask from that particular point of view. Because if, as sitting on an ethics committee, I would actually use as adjunct. For me, I often use the 4-box tools because it's very clinically relevant in a sense. And the committee that has lay people, so there are always clinical preferences, because if it's full of physicians, often clinical preferences will rule.
Yep.
But when you have, like we do, other people within other professionals within it, we have lawyers, we have, pastor, they come from the other point of view, like contextual and social point of view. That is also important to look at. And John and I have had a couple of discussions about that. We don't want an unbalanced view. So my thing about asking the question, I would look at it from that particular point of view. So if you're saying she's non-adherent, you telling her you have to take the medicine, if she really is taking the medicine, then it is probably true failure, then what is it? And then I would explore, is there anybody else other than the 9-year-old that can be just as good as a match? Because re-traumatizing a child, it may not be appropriate, right? So that's that balance.
Okay, thank you. I guess the voice of the child is not here. Nobody asked her, you know, does she even want the transplant? She's 15 years old, right? And we just talked about how you can't force somebody to forcibly have a bone marrow transplant if that's not what she wants. Yes, John.
No, that's right. So I was just saying, wanted to bring up that point too. You know, Ming was sharing. We know what the mother wants. The mother, you know, would like a transplant, but we have not heard from the 14-year-old girl, and you know, we have not really heard from that 9-year-old girl as well. Yeah. So I think it's important to engage the family, the mother, the 14-year-old with the disease, as well as the younger sister. And this would be part of looking at patient preferences, primarily for the patient, and subsequently we can filter this into you know, the quality of life and contextual features for the rest of the family as well.
Okay, great. Sorry, do you want to say something, Sarah? Okay, otherwise we will go on. The case, the plot thickens. So M's mother is a heavy smoker, and when told that she should stop smoking in order to look after M during transplant, she's worried that she will not be successful as she's tried to quit many times. She also expresses difficulty in taking time off work to be with M in hospital during transplant. We want a caregiver to be in the room with the child, because the child has to be in the room for up to a month. Okay, so we really need somebody to be there with the child. But the mother is still keen for M to have the transplant because she feels that this is the best option for her. Although she's unable to be with M while she's in hospital for the transplant, she feels that M is mature enough to look after herself, including taking medications after discharge from hospital. So the medical team is of the opinion that M should not have the transplant now, that there will not be constant supervision to ensure M takes her anti-rejection and her prophylactic anti-infective medications. There are also concerns that mum's smoking addiction may affect M's health with secondhand smoke. So M's mother is disappointed and feels that it is not fair for M to be denied the transplant because of circumstances beyond M's control. M's mother promises to come to the hospital as much as she can and will try her level best to supervise her when she's discharged. She will sign up with Quitline in an effort to stop smoking. So, second referral. Okay, the primary medical team are still very uncomfortable. So they refer to the ethics committee to ask if it is ethical to take the option of transplant off the table in view of the uncertainty in supervision and care during and after transplant. Okay, sorry. Right. Please poll. To be honest, I thought when I put it depends, I thought everybody's going to choose that.
Now we have strong opinions.
Yeah, that's very good. Okay, looks like most people are comfortable to take the option of transplant off the table. Any comments? Any further elaborations? Yes, Ross.
Thanks. I'm not comfortable taking the option off the table, not yet. I feel like we have to be really careful not to build in problematic judgments and stigmatisation of this mum. So she's in a pretty challenging social situation already. What's the impact on her going to be if her experience of this decision for her child has been that because of her, this hasn't been able to go forward? So I would want to see what other social supports we can put in place for the mum. So are there other things that we can do to fill this supervision gap? Is there other things we can do to support her with quitting smoking and so on? Just taking it off the table seems pretty harsh.
Okay, so look for other caregivers. Are there other caregivers, you're saying, or any other support system the mum has? Dominic?
So I think it's important to clarify what the question is and what the comparison is. So is the question whether transplant versus death is in this child's best interests, given some uncertainty about compliance and supervision post-transplant? Or is it the question whether transplant is better than continuing on some oral therapy or some second-line oral therapy? Or is the question that, given the uncertainty in this situation, the chance of it not ending well, is it a question of resources, where actually this is not a reasonable use of the resources? Or is it a question of, is it ethical to now take the donation from the sister who didn't really want it anyway, given this uncertainty? So is the magnitude of benefit for the sister now small enough that it's outweighed by the... So I think we need to work out which of these questions we're asking.
Okay, so clarification of the ethical question again. Any other comments? So kind of a bit of, maybe this might be facts, right? So are we talking about facts or are we talking about values? So the facts. If you don't do the transplant now, she's not going to die. It's not imminent death, okay? She can continue on her Gleevec. If she's truly taking it, like what Kumu was saying, it sounds like there's some resistance. Then she might have the option of switching it to the more expensive version. Then you're going to have, who is going to pay for it is a separate issue altogether, right? So is it safe for her to go through the transplant while you're not sure whether she's going to take her anti-rejection and anti-infective drugs consistently? And yes, that's going to cause death from rejection, from graft versus host, from infection of anything under the sun, viruses, bacteria, and all that. So it's a real possibility that if she does not take, she's not supervised properly, there's a risk that her outcome is going to be worse than if she did not have a transplant. Any other comments before I go to the... Yep, okay. They're so keen.
I think, again, questions all start with why. Why is she not, I mean, like whether she's, the same question, whether she's not taking drug or whether it's not working, or what are some of the apprehensions of M regarding taking medicines, what are apprehensions of P regarding her being a donor, why is mom not so, I mean, she's unable to do all of these things. So I think whys are the questions that we really need to find, and I think that's how we kind of get towards some sort of, you know, clear understanding of what's happening. I don't know, there might be different ways of doing that in different hospitals, but we kind of do it a little similar to that. We have a committee, and then we have assigned 2 members of the committee who are on-call ethics consultants. So whenever such a case, so even if it's not an urgent thing, like over whole month, those 2 consultants are kind of responding to the consults. They would go and meet with the family, with the clinical team, with the social worker and all other people involved in one way or the other, and then kind of, you know, talk to them, gather all the information. And I think, again, getting answers to these questions is extremely important, like why somebody is reluctant to take medicines and all of those things. So I think that might give us some clarity.
Okay, so more fact-finding. John?
I think if we use, you know, the idea of zone of parental discretion, I think it would still be within the zone of parental discretion, in my view, to keep that, you know, that to agree with the mom that transplant, you know, would still be one option actually. So I'm not clear that there is, you know, really significant harm, you know, if we pursue this option of transplant to this child.
So the harm would be if she doesn't take her anti-rejection drugs and anti-infective drugs, she's going to reject and she's going to have infections.
Taking the younger child out of the you know, that particular equation, I mean, the mum seems quite motivated in some ways. I think it would be important to engage the mother to see how far she would be motivated to make a transplant work.
Okay, so try and support the mother with you.
So now we may be looking at a request of and potentially inappropriate treatment. You know, if let's say we have kind of went back and look at whether BMT is actually the best option, and going by just not you know, scientific or clinical part of facts, and also the part that she was not compliant even with this oral medication, and you know what more post BMTs and everything. So I think if it's best in terms of all things considered, and you know it has been not on the table from the beginning or on the table, and now mother is requesting, and would we use a CBD, because sometimes it feels like, you know, it's always like the CBD is there sometimes for refusal of care, that we use it to actually kind of justify that in the end of the day it did not cross the harm threshold, and you know that's where, you know, we could actually have a bit of parental discretion because of, you know, uncertainties, or you know that there is 50-50 chance of things. But now it is more of, so I'm not sure whether I will come through a CBD point of view rather than just what is best for the child and go from there. So but it's just like trying.
It's kind of the zone of parental discretion, but on the doctor's side, though. It's the zone of doctor discretion. Assuming
I don't think we should be going down anything to do with transplant until we've sorted out the medication matter first. I feel we haven't quite finished that investigation yet. So why are we thinking about transplant when we haven't finished the medication thing? I mean, I'm hoping there must be some way of ascertaining whether she is indeed resistant or she is taking it and it's not, you know, so and it's not working. So I think we need to like have a definitive solution on that and look at alternatives, assuming that it's not so burdensome, these alternatives or the medication, that then you would have to start thinking about transplant. So yeah, because I mean, the moment you think about transplant, you're thinking about risk to other people, and then there's, you know, this whole, you know, and problem with the sister.
Yeah, Julian?
So, yeah, I just want to fluff that. It's probably a good thing I don't do clean ethics anymore. I mean, it's a case that's just boggling my mind. Sorry. So you're considering the most invasive medical intervention that there is, with, you know, high mortality, extreme morbidity, when you've got an alternative that hasn't been adequately trialled. And you also, as you correctly said, you need to be compliant on all these immunosuppressive medications. So you don't have compliance on a simple medication, and now you want to invoke this procedure, and which exposes a 9-year-old girl to a risk of death, pelvic collapse, infection. You know, it's just, I mean, there's not many cases that are no-brainers, but this one is a no-brainer, as Sumi said. Try the medication, and if you have an adequate trial of that and she's compliant and it fails, consider bone marrow transplantation. But I just think it would actually be unethical to offer a bone marrow transplant in this circumstance.
So I guess, okay, so some facts again. So the donation of the donor is not quite so morbid or you know, it's not trivial. Okay, it's not trivial.
People have this mistake. I mean, I actually wrote a paper on bone marrow, you know, volunteering children for bone marrow. There's a 1 in 100,000 chance of death. They have to be prone. You know, you drill, I don't know, 30, 50 holes into the pelvis. It's extremely painful. The bone can collapse. You can get infection. It's not something that you should take on lightly. And this kid doesn't want it as well.
Right, so there's another way to collect, and that's peripheral stem cells. So you don't actually have to drill holes in the bone marrow. You can actually collect stem cells. So that's one option. So I guess to be ethical, right, you need to provide options. You don't want to have medical paternalism, right? Unless it is really something that is really, really, like you said, you know, there's this option and everything else is harmful, okay? Because there is experience with transplant. So yes, there is side effects and all that, but there is a wide body of literature that it does work, right? Of course, yes, there's side effects and stuff. So to sort of to not be paternalistic, you should, I feel, you should give all options, all workable options, all options that is possible, right? And let the parents or the family make an informed choice, right? Sumi, you're going to say something?
Yeah, I agree with that up to a point, I think. And the point really that I'm uncomfortable about is if it didn't involve taking something from somebody else, then sure, give them the options, A, B, C, D, E. But the problem here is that you are having to carry out a procedure on someone who can't give consent because she's 9 years old and has had traumatic experience of being in a hospital and has already said she doesn't want to do that because she's really afraid, and the harm that could come from that. So sure, transplant is an option if everything else has been ruled out, and then you would have to start thinking about that. But even then, you know, you have to jump through many hoops before that becomes even something you would consider. So I don't know if I would, in these circumstances, give an option of transplant at this stage.
Okay. Any other comments? Yes, yes. Yeah.
Hello. Yeah. I think the primary medical team has probably reached this juncture after making sure that indeed there's a great difficulty from the patient as well as the mother to become compliant to many other things which is required for bone marrow transplant. So that's number one. In Singapore, it's $250,000 upwards of taxpayers' money, right? And when we treat this path, we have to be extremely certain that we use this money properly. I'm just putting forward angle of distributive justice over here, leaving aside all the other very valid points why it should not be put on the table. Yeah, so it's very, very expensive treatment. Yeah.
Okay. Any other? Pilin is there. Not Pilin, sorry. Pauline is there. Yes, Dominic.
So one of the interesting suggestions that sometimes comes up in these cases is whether it would be ethical to offer treatment conditionally. So, for example, transplantation might be offered conditional upon adequate compliance for a period of time with rising tumor markers, and you could. There are ways of measuring or enforcing compliance so you know that people have taken drugs, though sometimes they're more involved or invasive. Similarly, you could offer transplantation conditional upon the mother stopping smoking, contractually agreeing not to work for a period of time, being with the daughter, and you could enforce that in written. But often when those sorts of contracts are explicitly paternalistic. They are kind of setting conditions, and parents and families might resist those. So I wondered what other people thought, whether it's reasonable to set some ground rules.
Yep. So making them sign contracts.
Yeah, I agree, and I think one of the ways to move forward is to first also think about how quickly we have to make this decision, and like how quickly we have to make the final decision, and maybe we can kind of break it into different steps, like Dominic said, and I think that's part of what the mediation framework of consultation also does. You kind of bring them all to a table and see what are some of the challenges, what's happening, and up to what extent do they agree. So if M agrees to start taking the meds, if the mom agrees to quit smoking, and we can think about talking to P later on, but at least think about, so maybe we can divide or maybe do it as a stepwise approach, and if it's not like a very imminent death or a decision that has to be made like today or in a day or so.
Yep, there is time. Dr. Shinapa, you want to say something?
I think the fundamental issue with this family seems to be a psychological issue, with each one of them having their own problems. Okay, so I think the first thing we need to do is to have a joint psychological consultation to see why there is so much of problems within the family. So, and then after that, maybe something can be sorted out. Because I don't think that you can start looking at compliance of the mother to stop smoking and to be present when the child has had a transplant and to see that the child is compliant with medication. So all those things have got some basis of stress. So I think some psychological stress going on. So I think, and even the younger child past hospitalization, some psychological stress. I think psychological evaluation would be definitely in order here. Because if there is something that you cannot correct, or if this is resistant to change, then there's no point in doing anything at all.
Okay. I wonder whether it's really psychological or social. I mean, we have a lot of families who are like that. You know, it's psychosocial. That's better. Yeah.
I think we need to be a bit careful about pathologizing their stress. I think that the stressful response seems to me a very reasonable response to what is a very stressful situation. So I agree there needs to be supports around that, but I don't think that that lessens the value of the preferences and ideas that they're expressing. I also wanted to respond to Dominic's idea about the conditions. So I have some concerns about this. So my worry here is that if we go down this type of path, we're essentially compounding disadvantage. So if people are more likely to smoke if they're from a lower socioeconomic background. People are more not going to have the time, you know, to be able to take time off work if they're from a lower socioeconomic background. So I think if we start putting these kinds of conditions on, then essentially we're moving the access to this treatment is going to be limited to a higher socioeconomic group. So if we want to put these types of conditions on, then there needs to be huge support from the hospital itself to enable the family to meet those conditions. Because, yeah, I think having people have to take time off work means that there's just swathes of children who would not be able to access a treatment.
So I guess be careful of exacerbating health disparities. John, I think you want to...
Yeah, just want to add to the comments. No, I think the social aspect is very important. In all these cases, you know, we'll be deliberate at the CEC, and you know, typically we get a MSW or Medical Social Workers report in Singapore, and you know, just to explain myself to Mayok, who's the chair of our CEC, I typically don't respond until the social workers report is out, you know, because I want to see the entire picture, and you know, how, you know, does this child fit within the family? How does the family fit together, and whether there are other aspects to the relationships. So I think that's important. Another point to note is, well, in terms of contracts, you know, potentially with patients and their families, I'm not completely opposed to it, but my caution and my concern is that with such long-term chronic patients, we are working towards a long-term relationship with the patient as well as with the family. And I wonder whether such contracts would make it difficult to work in the longer period and process. Thanks.
Okay, so it's a good point. I mean, we always get a medical social worker report together with the referral so that we have whatever psychosocial issues settled. Yes, Caroline?
I wanted to respond to Rosalind's point about limiting access to lower socioeconomic patients. Actually, ironically, in Singapore, because the lower socioeconomic patients don't have to co-pay, they get full medical. So in fact, this is how I actually get my parents of my patients who are really poor and not coming to work, not coming to for appointments and all that. It's because the medical social worker says, unless you come and with your child, then I will give you your disbursement and all that. And that's how my patient gets care.
Okay, yes.
Well, could I just share a little bit about experiences if this case is in National Taiwan University Hospital? Okay, the legal background and all the process and SOP established is a little bit different. Okay, let me share a little bit. Yeah, because we just recently revised our entire organ transplantation review and also the legal constraint, everything, the SOP. So I think we are discussing in this ethics committee And there are many, many information we don't actually have. So it's kind of premature to ask the committee to do the decisions, okay? Because you need to, lots of preparations. Just like you want to airplane to take off, you need to clear the runway and lots of fixings, yeah. So the background is that if this is organ donation, okay, and then there are laws to be abided by, okay? We have Human Transplantation Act, and it will require that you have good medical preparation. Then you need to have one psychiatric counseling for the donor, okay, and also the social worker evaluation of the family situation and especially the willingness, the voluntariness of the donor, okay. You don't especially review the recipient, but the review process is mostly for protecting the donor. And then if this information is collected and it will come to the committee, and committee will send for another 2 medical experts for checking if this indication is fulfilled. Could it be that doctor is trying to do much more experimental, more adventurous transplantation for the patient? But bone marrow donation is not included because these are applied to the solid organ donation. But if this is a more risky one, we can actually follow the protocol established to do that. So I think the social worker evaluation will be very important. Not only the recipient, okay, there are compliance problems, and also the caregiver. Caregiver might have some caregiving, taking behavior that is also very important for the success of the transplantation. So it will need lots of counseling and lots of social worker evaluation, even support. So when you have more information or even intervention like that, okay, the healthcare team, the attending physicians must make sure that, okay, they are ready. And also the donor, because this is still kids, is more controversial. And she will need some time, okay? If the anti-cancer therapy is failing and the recipient waiting is more and more in risky situations, and if the donation of BMT is the final resolution, then we will be in a more dire and more challenging situation. So before we reach to that point, including the mother, for example, for some liver transplant cases, if the recipient has certain alcohol drinking behavior, we must make sure he quit drinking at least 6 months. So you must prepare in advance. Okay, if the recipient, the daughter is not like to take pills, you probably need some child psychiatric intervention, some behavior modification, some counseling, supporting her to be willing to comply with the post-OP, lots of the care procedures, things like that. So I think at this point, if you have all cases come to the committee, it will be just too many things we are not sure and unprepared. So it would be too difficult for the committee to make decisions, say this is ethical, is it unethical?
Thank you, thank you. I mean, in Singapore it's the same. The Organ Transplant Act is for organs. Bone marrow transplant is not included in the National Organ Transplant Act. And in the bone marrow transplant, the taking the anti-rejection medication is finite, is for a short time. It's not like an organ transplant, we have to take it forever. So in that sense, it is, I guess, less risky than organ transplant. And in a child who donates the bone marrow, the child can always produce the bone marrow back again. So it's interesting what you all said about, you know, a child donating to the sibling, because that's what happens all the time in the transplant for children world, right? Their siblings are the ones that have the best match. Although nowadays we have, you know, we are able to do it from parents and all that. So this issue, this uncomfortable issue about getting consent from assent from a child donor for the sibling is an ongoing issue. So let's go on. Okay, I'm going to go. Forget about this. So M finally recovered got her transplant. Okay, from her sister who was persuaded, with the father as a caregiver. Okay, so remember the father is around, he's just in a neighboring country, not too far. They managed to get him back, and he was a caregiver. But while in hospital, M's mother was diagnosed with stage 4 lung cancer. She requests M's medical team not to divulge her diagnosis to M in order not to upset her. She was in the middle of a transplant, right? But M suspects something is wrong when her mother has not video called her for a while and asked the medical team to contact her mother for her. The nurses are distressed that M is unaware that her mother is gravely ill and feels strongly that M should be told. So, third referral to the ethics committee. The nurses in the team now refers to the ethics committee to ask if it's ethical for them to tell M about her mother's illness. So, I'd like you to vote. Wow, 100%, is that right? So no debate. Any comments? What does it depend on? Uh-oh.
I voted it depends, and I think it depends what what M is asking. So if M asks the nurses, do you know why Mum hasn't rung me? What is there something going on with Mum? Then I think that the nurses need to tell. But yeah, so to me it depends on exactly what the young person's asking.
Okay, so you'll tell the nurses not to lie to her then?
Yes, not to lie.
Okay, okay. Any other comments? Yes.
I think a couple of things we need to think about. One is like sort of what's going on and being a little culturally sensitive about this, because a lot of times why a parent thinks like this is to kind of, in their opinion, they're trying to protect the child from this kind of news or information. And me and some of my colleagues, we've written about this in ethics rounds a while back. But I think this is very common in, at least in our culture, that a lot of times parents don't want their children to know even of their child's own diagnosis, or sometimes a father is trying to protect mother by not telling her that the child is so sick that he or she is dying. So that happens very frequently. So there is some cultural aspect to it. And again, I think, but trying to talking to them, and it might, being culturally sensitive, it might not be the responsibility of nurses to tell the child or M about her mother's illness, but talking to the parents and finding a way that they themselves kind of share it with the child.
So what is your answer, Sarosh?
So my answer is like talk to parents and kind of like trying to tell them like how important it for M to know, and being with her with her mom at this point in time, kind of think about those things and let them tell her in their own way, because sometimes families have their own dynamics and they better know how to talk or go through this. And as I said, like we wrote in that paper about, and there was a case in the US by a Pakistani family, and even the father added to that paper by saying that he was trying to protect his wife by not telling her that their child was dying, and he himself told her gradually, like over a period of days. So I mean, like that's what I'm saying, that families sometimes they know better how to disclose that.
Okay, so it depends. Dominic?
So I was just observing one of the sources of moral distress in these cases arises from the relationship that evolves over time between the treating team and the child. And it's particularly strong when there's an absent parent, because the health professionals, especially the nurses, become like parents. And they feel they develop an emotional attachment to the child, and they will, in those circumstances, grieve like it was their own child if the child dies. But I think identifying that that's what's going on, I think helps us to talk to the nurses about why it is that they're distressed, because they're relating to this as their child, but she's not their child. And so that, I think, helps us to also think about this. Different parents make different decisions. They might not be ones that we would make for our children. They might not be ones that we would agree. They might not be best for the child, but we also have to step back from our emotional attachment to the child and recognise that our role is not as parents.
Okay, so one last comment, because time's coming up. So one last comment, yes?
Can I just ask, who is the mothers, doctors and nurses? Are they the same team as the ones caring for M?
So no, she's in another hospital, she's in an adult hospital.
In which case then, I mean, if the nurses, the question...
This is the nurses, nurses after the child.
Then how do they know whether that information is correct?
Okay, so check with the information. Okay, time's up. I'm sure you all want to go home soon. So thank you. Thank you so much for all your participation. And before I let you go, can I get your two feedback? Because we didn't call this inaugural APEC for no reason, because we hope that this is going to continue. And we are planning to have this again maybe in another 18 to 24 months, maybe in a regional country. If not, it might be in Singapore, so we are still planning. And I hope that this meeting excites you all enough to want to join a network that we are hoping to form, the Asian Paediatric Ethics Network. There's going to be we're going to create a website in the CBME website. So I hope you all will keep an eye on it. And please, it's open to anybody who is interested in pediatric ethics, whether you are medical staff or not, or just interested party. Just sort of a few housekeeping rules before I let you all go. In the interest, this is an ethics conference, right? You want to be environmentally ethics, right? All these lanyards and stuff, it would be nice to recycle them. So if you don't want them anymore, so please put them on the table outside as you leave. And we'd like to thank many people for this interesting 2 days that's been happening. We'd like to thank Julian, because without his leadership and without his support, this wouldn't happen. Without his encouragement and pushing, this wouldn't happen. So thank you very much, Julian. Thank you very much, Prof. Roy Joseph as well, because without his wisdom and he's always very good at writing letters that is very persuasive. So all these nice letters that you all have is all Prof. Joseph's writings. So. And I also like to thank the scientific committee that's helped me come up with the program, Dr. Kumu, Dr. Aishwarya, I'm not sure if she's here, Dr. Aishwarya, and Dr. Vijay, okay, who has helped us come up with the program. And finally, I'd like to thank the people, the cogs behind the wheel, right, our admin staff, Karen, Chinket with his fancy shoes, our friendly timekeeper Glenn, Ross, who is outside, and Aruna as well outside. So thank you very much. This is really a team effort. And I hope all of you will be interested enough to join us in our next meeting. We are also planning to have online either webinars or virtual case conference and all that. So please keep your eye open. And if you want to be in touch, please give your email and your contact to the secretariat that sent your confirmation and all that. And please spread the word as well to anybody who is interested in pediatric ethics. Thank you very much, everyone, and I hope you all have a nice rest of the week. Thank you very much.
And a big thank you for Mayok as well, because Mayok has thanked everybody except herself. So thank you very much, Mayok, for your leadership and guidance.